right. Well, good morning, everyone, and welcome to the ACU 2020 virtual conference. We've got an exciting week of content planned, and if you haven't already done so, we would love for you guys to log on to the Crowd Compass app. You can either do that through your smartphone, or you can also do it on your computer as well. So either way, you can log in and get all the exciting information there. Once you do log in, there is a welcome video that comes up in your notifications box there from ACU's Executive Director, Amanda Piers-Kelly, in addition to all the other great resources available on that application. It's a great resource and way to network with other participants, and it gets you points for using the app. The person with the most points each day will, the person with the most points will win a free registration to ACU's 2021 conference that will, fingers crossed, be held in Washington, D.C. We're also giving away a Fitbit every single day of the conference, so check your Crowd Compass notifications. Welcome to the session today that we're here for, Decreasing Physician Burden and Burnout in a Federally Qualified Health Center by Promoting Team-Based Care. I'm Suzanne Spear. I'm the Senior Director of Workforce Development here at ACU, and I am serving as the moderator for this session today. Before we begin, we're going to go over just a few housekeeping items here. And the first of that is that we are recording this session, and it's going to be available through Crowd Compass in about 3 days. So you have to wait a few days, but it will be there on Crowd Compass, and it will be available for access there. Everyone is muted, and so please put your questions in either the chat or the Q&A box. We're going to be monitoring those boxes as we go along today, and giving those to Dr. Santos as needed. And so we're going to really try to have an interactive session as we can here and get those questions answered when you go ahead and ask them. If you're having any technical issues, please send a chat to our host, Mariah Blake, and she would be happy to get you all squared away and pointed in the right direction here. This session is eligible for 1 CME credit, and in order to receive that credit, we will check your attendance for the session, as well as check that you have completed the evaluation form that pops up at the end of the session. If you missed the pre-populated evaluation that pops up, you can also access the evaluation in the Crowd Compass app on this session page. If you aren't applying for CME credit, we still would really love to hear from you and want your feedback in the session evaluation, and really would mean a lot for us, for you to go ahead and fill out that evaluation form. So today's speaker is Dr. Jan Lee Santos, who serves as the Clinical Services Trainer for the Community Health Centers and PACE Senior Care Centers of Piedmont Health Services. Dr. Santos is an avid learner with a passion for teaching. Since 2018, Dr. Santos has helped to integrate 35 medical assistants, 15 medical scribes, and 10 cross-trained MAs and MS professionals into care teams. During the COVID-19 crisis, Dr. Santos has been co-leading PHS COVID community testing efforts in North Carolina, resulting in over 5,000 individuals being tested since April 2020. Dr. Santos received his Doctor of Medicine from Ross University School of Medicine, Master in Healthcare Administration from University of North Carolina at Chapel Hill, and Master's in Microbiology from Indiana University in Bloomington. You can read all about Dr. Santos in the Crowd Compass app. And with that, I'm going to turn it over to him so he can take it away. Dr. Santos? Dr. Santos, I believe you're still on mute.
All right.
There you go.
Okay,
Perfect.
perfect. Thank you so much for the introduction, and thank you for attending the first session of the ACU virtual conference. I hope that this is going to be an interactive session between all of us. So as I go through the slides, okay, the title of the presentation is Decreasing Physician Burden by Promoting Team-Based Care. Okay. Okay. First, I'd like to acknowledge some individuals who are not present in this presentation, who have played a big part in the success that we've had with the training programs. Have Crystal Terrain, who is our Director of Nursing, Jennifer Bradsher, our Associate Director of Nursing, Dr. Abigail DeVries, who is our Chief Medical Officer, and our Chief Executive Officer, Mr. Brian Toomey. For the most part, they have given me the freedom to design and implement and come up with the different strategies to integrate, train, and recruit all of our medical support staff. Okay. So just to give you an outline of the presentation, I'll give a brief overview of Piedmont Health Services, some of the provider burden that our providers experience, then redistribution of some of the tasks to medical assistants, scribes. I will then describe our PHS training programs and our future plans for this. Okay. So Piedmont Health Services, we're actually a private nonprofit health center that's been serving our communities for the past 46 years. So we are actually close to our 50th year anniversary. We are the first community health center here in North Carolina, and our mission is to improve the health and well-being of the community by providing high-quality, affordable, and comprehensive primary care. Okay. Most of our patients, we serve about 46,000 patients who are classified as mostly underinsured and underserved, and more than half have Spanish as another language to speak of. We employ a patient-centered medical home concept in which each of 10 of our health centers provide primary care services, dental, pharmacy, nutrition, behavioral health, and women, infant, children, as well as migrant farm workers outreach programs. Okay. And to just give you a geographical point of view, we have carved ourselves a niche in between UNC and Duke Health System, as well as Cone Health. So we are located in between Durham and Guilford counties of North Carolina. We actually like to joke that we take care of the patients that Duke and UNC does not want to take care of. We have 10 health centers, ranging from sizes of 5,000 patient panels all the way to 10,000 on each patient panel. We also have 2 senior care centers. These are the program all exclusively for the care of the elderly. So these are Medicare and Medicaid-driven programs in which we usually have anywhere between 150 to about 125 participants in each of our two health centers. So we're actually looking to possibly expand onto Lee County and Randolph, but so far we are doing a pretty good job as far as reaching out and taking care of the patients within our area. So this slide represents the burden that our physicians experience. These tasks can actually be divided into 3 major categories, which includes tasks done before the patient visit, tasks done during the visit, and then tasks done after the visit. Okay? When we did a survey of the tasks that our physicians and our providers were doing, we saw that some of these tasks can actually be redistributed or be assigned to other members of the care team. Okay? So other members of the care team for us include, we have patient care coordinators, we have medical assistants, we started integrating medical scribes recently, and then now we have a medical assistant, medical scribe hybrid, which does those duties. Okay. So the main point of the task redistribution is number one, we do recognize that providers have too much burden on their hands. Okay, they do not have enough time to do it, and this is contributing to burnout. And for us, we have physicians, it contributes to physician turnover, and then a general lack of or a decrease in workplace satisfaction. Okay? So when we take some of these tasks that's done before, during, and then after the visit, decided to redistribute these tasks to the other members. Okay. And who are these other members? Then the first member that comes to mind are the medical assistants. Okay, so these are folks or staff that generally play a direct role as far as seeing the patient first. Okay? So what we did over here was we took some of those physician tasks and then reassigned and then trained and empowered our medical assistants to do these things. Okay? So now some of the tasks that has been redistributed include checking for required immunizations or preventative screenings, preparing equipment and supplies for tests and procedures. Arguably, those are already tasks that are being done, but previously, some of those tasks were actually still falling to the physicians. Okay? So we just ensured that some of those tasks are really designated and then owned by the medical assistants. During the visit, rooming the patients, checking and recording vitals was important, and then administering immunizations if needed. These are just some of the things that they have been trained to do. They do other things such as checking for depression, checking for immunizations and preventative screen status, but these are a few of the main things that they have done. We also found out that after the visit, many of our physicians were doing follow-up calls and results. So we thought that those are tasks that can also be relegated to the medical assistants. So they are now all trained to perform follow-up calls and administer results if needed. In addition, this plays in a huge part as far as the pediatric populations was the completion of this school or education-related forms, and now most of these are falling under the task of the MA. Previously, our pediatricians were doing that, so we offloaded that and onloaded the task to the medical assistants. Probably the newest member of our care teams are the medical scribes. We started first having scribes around that 2018. At first, it was not really clear as to what was needed out of them, but then we finally streamlined and empowered medical scribes to really take ownership of doing documentation and basically knowing what's on the patient chart. I remember back then when I was doing my medical training that my physician preceptors would be spending the night before reviewing charts for the patients that we would see the next day. So we assigned this task to the medical assistants. So they're involved in reviewing the patient notes, taking note on the pertinent diagnosis, any special medications, and importantly, allergies that the patients may have. They're also involved in importing consults, reporting any results from ER visits, hospital specialists, or imaging results. So basically, they help prepare the information that the provider is needed for the actual visit, so that the provider doesn't have to take time to either check or try to remember and not have to spend time, too much time knowing what went on. Okay? During the visit, we have encouraged providers to really let the scribe do the clinical documentation. So this includes capturing and recording the history of present illness, the past medical history, review of systems, physical exam, as well as the assessment and plan. One of the things that we had to standardize was the expectation on how roads were written, because some providers would like a story, full sentences, paragraphs, but then some would prefer short bulleted information. So we just standardized that for our providers to expect short bulleted sentences, since those are the standards that's expected when physicians take the USMLE Step 2 clinical skills exam anyway. Okay. After the visit, scribes have taken ownership of entering orders, charges for the clinical visit, as well as perform any other needed tasks. Okay. So some providers have been really good as far as letting go of some of their tasks, but then we still have some who are still adamant of writing their note, even though they already have a scribe, but then use the scribe for other things. So as a result of this, since we have uploaded some of the tasks that the physicians used to do to the medical assistants and the medical scribes, we actually started having happier providers. Okay? Over here is a picture of one of our model care teams. This is Dr. Susan Pitts. She's our pediatrician. Henry, our scribe, have been working with Dr. Pitts for about 1.5 years now, and then Holly have been working with Dr. Pitts for almost 3 years. So this is actually the model that we wanted, so where we would have a teamlet of a physician, a scribe, and a medical assistant who gets along with each other and help each other to perform all of those tasks that was normally either performed by the patient themselves or by the medical assistant by themselves. So this is actually the one of our model care teams. Okay, so this allowed the provider to focus on the patient more, since they don't have to worry about charting and interacting with the laptop. Some of them have shown that they have more patient interaction, since their face is not glued to the laptop. Okay. Less interaction with a computer or the laptop was always a must. Okay. Less time charting, and some have expressed some higher workplace satisfaction. One of the most common comments was it is nice to have a team that you normally work with who is happy to see you every day when you come into work. So those were some of the effects of having a team that has been working together for quite some time. Okay. So some of the provider testimonials. So the scribe has really increased my productivity, increased my face-to-face interaction with patients, and decreased my after-hours charting. Without a scribe, I was feeling overwhelmed daily and thinking about retiring early. Okay, so with a scribe, I'm enjoying medicine again. So when I actually put out the survey, I didn't know what to expect. So when I saw these answers, I was like, oh, wow, this is great. This is exactly what we were hoping to see. Okay. Working with a medical scribe has transformed the patient experience for me. I can now listen to and look at the patient instead of just a computer. I provide much better, more complete care with the scribe and have less conflict at home and less time charting after hours. And I decided to do some quotes over here because some of the providers actually made some specific comments about their scribe. So Hanan was a scribe that I hired and trained last year. She graduated straight out of college, and this is her first job. And she's been one of our most heralded and most liked scribes in Piedmont Health. And this is Dr. Ratika Malindran. She was a resident with us who has now joined us as a part-time physician. Okay. Some other ones is scribes have been life-changing. Okay, I used to spend 10 hours a week at home charting, and now it's around 4. So that's a significant reduction in the amount of home time doing work at home. Okay. Scribes and medical assistants are one of the most helpful things that we have done. We are now actually using scribes and medical assistants as a recruiting tool. Whenever we would hire a or attempt to recruit a provider, we will say that we'll provide you with a medical assistant, and if you like, we can give you a medical scribe. Okay? Very dependent upon my scribe and medical assistant. The medical assistant anticipates my needs, and then the scribe takes care of most of the documentation. So these were some of the effects that we were really wanting to see. Okay. So when we further do a evaluation of some of the tasks that they've done, the blue and the green is showing strongly agree and agree. Okay, some of the icons are covering this up. Okay, but we can see that the scribe makes the workplace more enjoyable, increase workplace satisfaction, even stress levels at home, stress levels at work. Okay. And then scribes are a valuable addition to the PHS care team. So we can see that out of the 13 providers that we surveyed, almost more than all of them have rated the scribes either agree or strongly agree as far as the questions that we have over here. Some of the most helpful tasks of scribes were actually reviewing patient notes, importing the consults. I was surprised that the documentation fell halfway, but that's what they said. Okay? And some of the other tasks that was not as helpful were like cleaning notes and updating problem lists. One of my first jobs when I came to PHS was actually I was the one updating the problem list for all of the providers, and that got overtaxing after a while. Okay. All right. As far as the scribes, since we have implemented and empowered the scribes to do other things that they haven't really normally done, I have 2 tasks that have really improved when we implemented the training programs. Okay? And number one, this is arguably a very simple task, but it was actually something that we were not doing very good of during the beginning of 2017. And this is the checking blood pressures. Again, when the first blood pressure check is 140/90. We're always trained that if you see a patient and you check the blood pressure and it was 140/90, you're supposed to leave the patients in a quiet room for about 5 minutes, and then recheck the blood pressure to ensure that there was no white coat hypertension or stress-induced hypertension because the patient was running late. We were finding that we're dropping to almost 5% to 10% of patients eligible for rechecks were not getting a recheck. Okay? And if the medical assistants were not doing that automatically, the providers were having to ask for it or do it themselves. So that was another additional brain work and task that the physician had to do. Okay? So once we started doing a training and QI project on this, we were able to increase BP rechecks from 20% to about 45%, and then now to about 65%, and sometimes hitting 80%. So just this simple task was actually one of the comments that the providers really appreciated that the medical assistants started to do and take ownership of which is something that they used to do back then. A few other things was the depression screening. If the medical assistants didn't do them, the providers used to do them. So now that we have empowered assistants to do PHQ-9s, we've seen an increase in the percentage of folks needing or receiving the PHQ-9 screening. As we can see over here, from almost about 55% to about 90% post-implementation of the MA training and the empowerment. Okay. And the one thing that we didn't expect was when we were screening more, that actually resulted in more behavioral health visits for our behavioral health consultants. So that was another revenue generating result that came out of this initiative. Okay. And then now that we were starting to have the medical assistants and medical scribes being integrated to care teams, we started hiring individuals who are college graduates who were originally designated as scribe and medical assistants, but then wanted more duties because they want to go to medical school or PA school or nurse practitioner school. So we decided to create a MA scribe hybrid. Okay? So these are individuals that are dually trained to perform both a medical assistant and scribe task. They act both as a medical assistant and medical scribe for the provider. So they're both doing hands-on and computer and EMR related tasks. Okay, so this actually provides additional experience and skills for the individuals who are dually trained, so they're able to do more. So one of the skills tests is that I teach them how to draw blood, and I have Mukal over here, and you can see over here that I'm the guinea pig test patient. Okay? So I always believe that if you teach your trainees and students well enough, then it won't hurt. But you can see I have no fear in my eyes, right? All right. Okay. So those were the results. So then the second part of this talk is to talk about how we got there. Okay. Before I started at the PHS, we had a sort of a non-structured onboarding program where recent hires are just automatically put into the clinic, and then they shadow or learn, or they just learn whatever they can. Okay. I think this went on for about 3 or 4 years before it came in, and the turnover was quite high. So the first thing we did was to put some structure into our onboarding program. So I created a medical assistant and scribe training program to train and ensure that the individuals that we're hiring have the skills and the competence to function at the clinic in a short amount of time. I basically get them working and make them as competent as possible to do the task. And then number 2, give them a sense of a feeling that we're investing in them so that they stay and do a good job with us. Okay? So the purpose of the programs is to, number 1, train non-medical assistants and non-medical scribes into what we would like for them to be. Okay? So provide both the academic and clinical training, reinforce standard workflows and protocols. We have 10 health centers, and a few years ago, each health center had their own workflow to perform the same thing. So that meant that a medical assistant in Scarborough, when they go to Prospect Hill, is like going to a brand new place. Okay? So one of the emphasis that tried to do was to ensure that workflows are standard so that a medical assistant or even a scribe can go to our different sites and not have to worry about trying to learn a new workflow. Okay. Is there a question there? I am hearing some movement. Okay, perfect. All right. Also an emphasis on team-based care. We are now part of a team, and on customer service. The simple act of greeting a patient and referring to them by their name and saying thank you and have a great day was lost, and that is something that we emphasize now. We consider this training programs as an opportunity for career advancement. They receive in-house training, they gain new skills, they're exposed to healthcare-related careers, and really one of my main goals was for this to serve as a stepping stone to a health professional program. This helped us fill a need because earlier, a few years ago, for every medical assistant position that we had 0 applicants. Okay, but then if we would post in a advertisement for a CNA, would get 4 or 5 applicants. So we thought, why not train some of those CNAs and then train them to be MAs, since we had more applicants that way. Many of our patients speak Spanish. Okay, we now also have a growing number of refugees from Myanmar who speak Khmer, some Syrian refugees, as well as some Asian population base is growing, which includes the Chinese and Koreans who are coming in. So we needed to have staff that are bilingual and representative of the patients that we're serving. And then lastly, if our staff is trained, they're more versatile and they're more skilled to perform the jobs that we are asking them to do. Okay. So this is just a description of the medical assistant training curriculum. We scheduled it for 5 weeks or 25 business days. Since many of these hires are CNAs or phlebotomists, we decided to give them a basic science curriculum. So that's basically 10 days with me. We go over basic human anatomy and physiology. Okay. They do have a clinical curriculum. We do clinical skills, assessments where we have checkoff. They do rotations at various pages departments. And then they spend time shadowing our senior MAs. Okay? So this is something that they've never, or hires back then did not experience, was the organization of their onboarding. And we also provide about almost 1 day for training with our EMR trainer. Okay? So we try to have fun. So when the human body exhibit was here, I would take the trainees to visit that, because that's one of the best ways to see the human body. Okay. All right, and just a sample of what we go over. So we have the academic, and then we have a skills checkoff list. The skills checkoff list is something that we try to train and then do and then finish within the 5 weeks that the MA is with us. So this ensures that that they are ready and have done at least once or twice the procedures and tasks that they're supposed to be doing once they go full-blown into clinic. Our medical assistant training profiles, we had mostly a lot of CNAs apply to us with 2 to 10 years of experience. They're coming from nursing homes, ALFs, wards. We have former phlebotomists, recent graduates who have not taken the certification exam. We actually had 3 that said that our training program helped her pass the exam. She was previously studying on her own, but then she went through with us, and then she eventually passed the certification exam. Okay. Also started recruiting for recent college graduates who wanted to go to PA, MD, or a PA school. Okay. Darwin over here was one of my hires. He just started PA school at Pfeiffer College 6 months ago. So we're hoping for him to come back soon. And then most trainees are fluent in second language, Spanish, Khmer, and other things. Okay. Just speed up. Okay. So since the MA program began, we've got about 33 trained. The comment there is they're more motivated and more eager to do newer things compared to the ones who did not go through the program. And this has also helped a lot with our retention. Okay? So we do, once again, try to have fun, and then folks have started to stay. And just to quantify the retention, okay? So the blue bars are the retention of the previous regular program where there's no structure. Then the red is the retention with the new structured program that we implemented. So we can see over here that especially when we start getting to the 12-month retention, we're now retaining most of our medical assistants compared to the half. Okay? At 18 months, we still have most of our MA trainees, and then the ones who have not gone through the programs have really not retained as much. Okay? Still at PHS. Okay, so folks that went through the regular program, 5 out of 21 is still with us, but then the new structured program, we still have 29 out of the 33. So this has really helped as far as retention goes and decrease our turnover. And one of the comments was that it's just nice, or by the providers, is that it's nice to be working with an MA for longer than 6 months, because once you've got that longevity, the MA is able to anticipate really what the provider needs and want and likes and dislikes. Okay. So when we do retention by site, okay, so we can see over here that the program has really improved retention over 3 sites from almost 0 to 70% to almost 100%. Okay. So one site over here, she has retained all of the medical assistant trainees that I have, and she said that she's never had a better group. They all work together, they help each other, and they all get along. Okay. The medical scribe training program, we scheduled this for about 2 weeks to 10 days. Had about 5 half days of didactics, which includes building the note, practice note writing, lectures on common conditions that we see at PHS, and then most importantly, one of the most common symptoms that we encounter is pain. So we talk a lot about abdominal pain, headaches, muscle pain, because that's what we see. They get more EMR training than the medical assistants, so they get about 3 half days compared to the 1 to 2 half days. And then they spend about 12 days shadowing a senior scribe. All of our scribe trainees are recent graduates. UNC is just down the corner. So I started recruiting at my old department where I did my MHAN, and then started recruiting from the biology department. And, once we hire one, all of a sudden we get 2 or 3, even 4. Okay. So at this point, we have about 2 or 3 that came from the chemistry department. Who are wanting to stay with us, and then up until when they get to medical school. So since the program inception, middle last year, we've had quite some success in getting about half of them into a medical school and PA school. So that is exciting for us. That's also exciting for me because that was one of my personal goals when I created the programs, was to ensure that these individuals have the opportunity and have the capacity to build their resume and get into a professional program. So we also actually tried to give them a research project, a QA project, and try to get them do some presentations. So that helps enhance the applicant's resume so that they can get in and make them more competitive. Okay. As far as the cost and time and investment, really, we basically just organized the time that the MA spends. So back then, we were spending 6 to 7 weeks in clinic, not really doing anything. So we just organized them to 5 weeks. So essentially, the amount of wages is still the same. The only thing that we added was they spent some time with me. So that's the 4 hours per day for 11 days with me, and then including the 1 day for the clinical skills learning and assessment, and then 4 hours with the EMR trainer. So the cost is the my wage and then our EMR trainer's wages. Okay. I really prefer that we train MAs in cohorts. So we usually train them in groups of 3 or 4, because if we do that, then the cost per MA goes down. I think at one point, if I was training 4 MAs, the cost of training for MA goes to less than $800, because my wages or my price is divided between the 4. Okay? Medical scribes are actually budget neutral, meaning that they do not add to the expense. We wanted to we made a deal as to where if a provider wants a scribe, they will have to see 1 extra patient per day. So we add 1 patient to their template that they have to see, and that 1 patient, what we earn or what we collect from that 1 patient is enough to cover the pay of the scribe. So the cost of these programs is almost negligible, since we really just organize the time and then ask providers to see 1 extra patient per day. Okay. So for the future, I always emphasize that folks need to be advancing professionally. So we have a career ladder now for the MAs, MA1, 2, and 3s. They come in as an MA1, and then we train them and for additional skills to be an MA2, MA3. MA3, they can choose between an administrative or clinical focus. So for some of them, they like to do more clinical scribe work, but then some likes to do more office, patient care coordination work. We're also doing now a trainer, where we are training the MA preceptors to ensure that standard knowledge is passed. Okay. We're going to try to do more recruitment and cross-training of scribes to different roles. So instead of like vertical advancement, we have horizontal advancement, where a medical assistant, scribe, and patient care coordinators can do each other's job sequentially. Okay. And then lastly, this more like a personal goal is to eventually pursue official certification for the training program, because number 1, we certify the MAs in PHS, but then when they get out, they don't have it. So I'm looking into ways to actually make our training programs officially certified. Okay. Okay. So at this point, it's about 11:43. I'll entertain any questions that folks might have. Thank you for listening to this presentation, and I hope that you're able to devise or learn some tactics and strategies that can be used for retention and integration of other team members in the care team. Thank you so much. And I am now going to pass the presentation back to Suzanne. Okay.
Perfect. Got it. Thank you, Dr. Santos. And thank you for that wonderful presentation about scribes and MAs. I know I learned a lot, and I've often heard about scribes, but enjoyed getting to hear a little bit more about them and what you guys use them for at your health center. So as Dr. Santos said, we would love to entertain any questions that you guys might have. We have some over here in the questions box. So the first question is, how many patients per day do your providers see? And how do you train your providers to utilize the scribes? So 2-part question.
Yes. So for our centers, providers are required to see 20 patients per day, 10 patients from 8 to 12, and then another 10 patients from 1 to 5. So we really had to, for the providers that we gave a scribe to, we really had to train them as well. One of the things I did was I would talk to them that the scribes are actually college graduates, so they actually know the terminology. So if you can just try them, and let them go and take ownership of the note for about 2 or 3 days. Okay, if you don't like it, we can revisit. If you like it, then we move on. So we really go on that trial period, and then we also do a lot of since we already have about 2 or 3 of those model MA scribe teams. I always ask those teams to share some of their best practices, and mainly the providers who have those teams will say it's okay to let go of the computer and of tasks and just trust your team. So once that's happening, and then once we prove that the ones that we are hiring and training are competent and dependable, the providers eventually learn to trust them. And we also do a trial of, we give them 1 or 2 scribes to choose from. So we will have a trial period of 1 scribe for 1 week, then another trial with another scribe, and then see who they like and who's going to be a nice interaction with them.
Great. Any other questions? Thank you so much, Dr. Santos.
You're welcome.
Okay, we'll wait a second or two for any other questions to come in. You actually answered my question, Dr. Santos, because I was going to ask if there was any team building that you guys did, but you answered that kind of in the 2 scribes there. So thank you so much for that.
Yes.
Okay.
And also another thing that we started doing is we started hiring providers who are 65 and above, and some of them they don't agree very well with the laptops. So now with those providers, we really assign scribes for them.
Perfect. Great. Yeah, it's definitely a great way to help have those providers on board, but yet relieve their burden and really take that off their plate. That's awesome. Wonderful. Well, it doesn't look like we have any other questions. So thank you again, Dr. Santos, for this really informative presentation. I know I enjoyed it, and I know you guys did as well. So next up in our virtual conference, we have our opening keynote, Transforming Healthcare in the Age of Pandemics. Can health equity be achieved? I know we've talked, it's kind of been the other thing that we've really been talking a lot in the healthcare space right now is health equity. And so we hope you'll join us for that. And before you join us for that, please go ahead and make sure you filled out your session evaluation, especially if you're applying for CME credit. But even if you're not, please go ahead and do that as well. One thing I also wanted to mention that these slides are they were just uploaded under the Crowd Compass app. So if you want to read the information again and take it back to your team, feel free to do that. And like I said at the beginning of our presentation, the recording of this will be available in about 3 days on the Crowd Compass app. So again, thank you to Dr. Santos for being and joining with us today and your presentation, and for all of you for joining us as well. So thank you so much. I hope you guys have a great day, and we look forward to seeing you in our opening keynote in about 40 minutes. So thanks, everybody. Have a great day.
All right. Thank you so much. Have a great day.